duplicate discount prevention, and mixed-use hospital operations data reporting. These are the areas where small gaps can create major operational, financial, and compliance risks.
For a hospital without in-house pharmacies, and they just have contract pharmacies, and they bill for physician-administered meds. That's harder to determine, to be honest.
Right.
But if you carve in, at the very least, your profit margin is dispense fee. They should actually monitor it on a more of a macro scale. So not really looking into the little details, or looking at the impact of the 340B program as a whole. So in the end, the 340B program is all about cost savings. So you would run your wholesaler purchase history and identify your WAC cost versus your 340B cost. Does it make sense?
And Vinson, you may have heard about a lot about AI, automation, and everything. Do you think AI can play a role in preventing the duplicate claims issue? Welcome to 340B Pulse, a North Arc Health podcast powered by Purologix. I am Muhammad Atif, your host and CTO and founder at Purologix and North Arc Health. 340B Pulse is about practical operator-level conversations, not just policy, not just headlines, but real discussion about how 340B program works, where they break down, and what covered entities can do to strengthen their programs. And today we are talking about a very practical topic: duplicate discount prevention and mixed-use hospital operations data reporting. These are the areas where small gaps can create major operational, financial, and compliance risk. A missing medical flag, a data mismatch, an unclear vendor process, a mixed-use mapping issue, a report nobody is reviewing closely enough. These things may look small, but they can affect the health and defensibility of the entire program. And to help us unpack this, we are joined today by Vinson Tran. Vinson brings practical experience across duplicate discount prevention, mixed-use hospital operations, data reporting, compliance oversight, TPS software visibility, and 340B performance improvement. Vinson, welcome to 340B Pulse. We are really glad to have you here.
Hey, Atif, thanks for having me.
Yeah, so thank you, Vinson. So before we get into the details, can you share a little about your journey into 340B and the kind of work that shaped your view of program operations?
It all started when I was a pharmacy intern at a community hospital. And when I transitioned to a staff pharmacist, I actually saw how the 340B program was being misused. And there was a lack of oversight, lack of understanding, really. And maybe a year or two down the line, it got shut down. And fast forward a couple years later, I was assigned as a lead pharmacist at this institution, and I was tasked with helping with rebuilding the 340B program for that cover entity. And after I rebuilt that 340B program, which involves setting up purchasing accounts, making sure the pharmacy software works as it should, onboarding 340B TPAs. After all that, not surprisingly, HRSA came after us and flagged us for an audit. So, and after that happened, I took a different route and actually took a core 340B role at a different hospital. And at the same time, I founded Pharmacy Operation Solutions, which is an LLC that I currently run. And I help other cover entities kind of give them a little guide on how they can manage their 340B programs. And it's not just limited to dish hospitals, but also to community health centers as well.
Got it. Awesome. So tell us about that HRSA audit that you were talking about. How was that experience and how did you cover that?
Even though that was 4 years ago, I just had another HRSA audit just last month.
Wow.
and it applied the same auditor as well. It's a little nerve-wracking, and it's something that I will highlight probably later in the episode, where it involves every single player, the billing team, the input system analyst team,
Mm-hmm.
the pharmacy team, and our core 340B team, and also hospital administration. Everyone has to pretty much get together to get the data that HRSA needs, get the data together to kind of validate what HRSA needs. And even though it was very a lot of work just to get the data together, but because we built a strong foundation and we also contracted with an external auditor to kind of routinely monitor 340B program compliance, we're able to get the data that HRSA asked for. And it's good that HRSA gave us maybe about a 1 to 2 month prep time to send the data that they need, and they send us the samples that they will be looking into. So it gives us time, maybe a few days time, to kind of look over the claims and see whether we are in compliance or out of compliance. And if we are the latter, we will have to kind of find a way to explain ourselves. The point of the auditor to come on site is just to gather data. They're not
Mm-hmm.
here to come up with a decision. So that's one
Right.
thing I would let cover entities know, that they're here to gather data. They're not going to give you an answer right away. That doesn't come until up to 6 months later.
Well, let's start with duplicate discount prevention, and let's go step by step.
Sure.
So a lot of people think that duplicate discount prevention is one of those areas that can look simple from outside, but inside a cover entity, it touches almost every part of 340B workflow, from data and billing to Medicaid decision, vendor process, and ongoing review. So my question is, on paper, duplicate discount prevention sounds very simple. In reality, what has to be working behind the scene for cover entities to prevent duplicate discount effectively?
So there's two universes that I would want to address. One
Mm-hmm.
is in the mixed-use retail space, which includes an in-house pharmacy.
Right.
The other would include the hospital space,
Right.
mixed-use pharmacy as well. So with the retail, even though they say duplicate discount is simple, it is as simple as they say for the in-house retail pharmacy.
Mm-hmm.
It's basically just getting your adjudication data, or at least retail pharmacy data, and then gather 340B data from your 340B software and match it. Any Medicaid claims, because duplicate discounts generally refers to carve-in entities that use Medicaid, any Medicaid claims that show up in your 340B accumulator should match up the modifier, which is the 08 or the 20 submission clarification code that you need to submit to Medicaid. So as long as there's a match, then you're good. You're in compliance. If there's a mismatch, then you have to ask yourself, why is there a mismatch? And there's ways to correct it. You either make adjustments in the 340B software or make adjustments in the pharmacy software. So that's in the retail space, and that's something that that can be done on a monthly basis to keep up with preventing duplicate discounts. On the hospital side, it's more complex
Mm-hmm.
because unlike the in-house pharmacy, where pharmacy owns the whole operations from the beginning to finish, in
Mm-hmm.
the mixed-use hospital side, you have to deal with people with the hospital EMR, the IT team. You have to deal with the billing team. You have to deal with the pharmacy team, and there's several layers of the inpatient pharmacy where you have to deal with inpatient pharmacy, the outpatient hospital side, which includes surgery and also emergency departments, which are considered to be very eligible. So because of these layers, it makes it a little more difficult to prevent duplicate discounts in that sense. But if you pretty much bring it down to the common denominator, it's possible. So what I found out through my years of experience is that each software utilizes a charge file that's sent from the hospital EMR. Depending on how the hospital sets up the files that are sent to the splitter, that would be how it works. So, for example, there is a hospital EMR that uses unique transaction codes. They every time there is a medication dispensation, there's a code assigned and it gets charged. Any charges would go through billing. So that is what the common denominator that I have determined from my experience that gets sent to the splitter, and then that gets to the accumulator. One of the good things about 340B software is that you can filter by Medicaid fee-for-service claims, and from there, that is your sample. That is what you use to review audit claims, whether the modifiers are correctly placed. So on the hospital side, you need a UD modifier with the actual acquisition cost. So that gives you the data you need to review whether or not they're in compliance. Again, like I said, there are many players involved. So any changes that occurs on the IT side, any changes that occurs on the billing side, that's going to impact on whether you're compliant with duplicate discounts. And most of it actually falls off the 340B team radar. We don't find out until after the fact. And then we work to help resolve the issue.
Got it. And how should hospital think about medical carve-in and carve-out decisions?
Pretty simple. Well, I come from California, so we're mandatory carve-in. So there's 2 carve-in states, California, Illinois. And so I've never really had to deal with the question whether or not we should carve in or carve out. But for hospitals in states that has the option, you have to take a look what the Medicaid reimbursement rate would look like to carve in. It's easier to see that in a in-house retail sense because you know exactly how much you get reimbursed. For a hospital without in-house pharmacies, and they just have to contract pharmacies, and they bill for physician-administered meds. That's harder to determine, to be honest.
Right.
But if you carve in, at the very least, your profit margin is dispense fee. In California, in some cases, the Medicaid reimbursement is less than what you would pay for at wholesale costs. So that you have to balance out how much you get paid versus the savings, and that kind of helps dictate whether you should carve in or carve out.
Got it. And how important is Medicaid exclusion file accuracy?
You don't use a file, but when I work with auditors, they make a big deal out of it. And part of it is because the state Medicaid agencies, like DHCS of California, use this file to determine rebates, if rebates should be paid. So it helps the state. And in an HRSA audit, they require you to have that medication exclusion file available. And if all your carve-in, carve-out decisions should be reflected in the MEF.
Right. And what mistake do covered entities make when they assume that their systems or vendors are already preventing duplicate discounts?
The mistake is trusting that everything stays the same and that everything's working properly. And it's just not understanding that 340B is a dynamic world. And as I mentioned earlier, any changes in billing process. So I give you a quick example, like for billing, they changed the process of billing where they resubmit charges based on the patient financial status or the patient inpatient or outpatient status. So whenever that changes, it resubmits multiple charges. Multiple charges means multiple accumulations. In most setups, that's how it is. And just right there, you've already have a risk of non-compliance already. So again, don't trust the system. Trust the workflow that you create to identify any inconsistencies.
Got it. Right. So, Vincent, let's talk about mixed-use hospital operations. As we know that mixed-use hospital operations can become complicated because pharmacy purchasing, billing inpatient, outpatient, and reimbursement data all intersect. When those workflows are not aligned, the program can become difficult to manage and harder to defend. So my question is that what makes mixed-use 340B operations challenging in the practice?
It's challenging because, as mentioned earlier, any low deviations in any of these processes can result into non-compliance or actually loss of savings. Right. So because most 340B splitters, they utilize charge data. So if the charges aren't submitted, then you get no accumulations, which results into loss of 340B savings. So that's the opposite end of duplicate transactions. You get no transactions. So it's complex in a sense where if you trust the system to work the way that it is, you're going to end up with non-compliance and a loss of savings. And one of the challenging parts is trying to find a workflow to identify these issues. So, and not everything is set in black and white. The hospital EMR maybe use one transaction number, but the 340 splitter uses a different identifier to say the claim is unique. So what I do, again, as a temporary Band-Aid, is to create a new unique identifying number, unique ID number that's only unique only to that transaction. And that includes using the hospital transaction ID, the date, the time that it was given, maybe the NDC of the drug, whatever it takes, just to identify that transaction as unique. And that allows me to submit tickets to the 340 splitter to remove any duplicate claims. So this is a process that I designed for one cover entity, and eventually we were able to find the source of the issue. The source of the issue was on the IT side, on the charge files that are sent, not on the billing end. So part of it, again, find a process to identify the issue.
Right.
And once you find the issue, such as the charge file, then dissect it, work with your information system analyst to see what's disconnect, why did it happen. And it takes a person that can speak both languages in the pharmacy sense and also in the IT sense to kind of figure out what's going on.
Got it. And I totally agree on that, Vincent. So what should hospital monitor regularly in mixed use environments?
They should actually monitor it on a more of a macro scale. So not really looking into the little details. We're looking at the impact of the 340 program as a whole. So in the end, the 340B program is all about cost savings. So you would run your wholesaler purchase history and identify your WAC cost versus your 340B cost. Does it make sense? If you have a lot of WAC purchases and low 340 purchases, and you're primarily a 340B hospital, something must have happened. But sometimes that doesn't tell the whole story. You'll also have to run your hospital transactions to see how much of these transactions are inpatient versus how much of these transactions are outpatient. And then compare the percentages, see if it makes sense.
Got it. Right. And do you think that this monitoring can reduce errors and compliance risk and financial leakages?
These monthly monitorings can help, again, maintain compliance by making sure that what you purchase is in line with your transactions. And in terms of financial leakage, you want to make sure you don't want to miss any opportunities. With hospitals, let's say with an infusion center, which actually generates the most revenue, but also generates the most cost savings, you want to make sure that these high impact drugs are looked at very closely. And this is, what I do with some cover entities is to focus on these, I guess what I would call high impact WAC drugs, and try to make sense of the purchases that are made, and make sure that no missed opportunities are there.
Got it. Right. So, Vincent, let's talk about data reporting and review rooms. So, many cover entities have data, but the challenge is knowing which reports matter, what to review regularly, how to run reporting into action. A report shouldn't just sit into a folder. It should also help leaders see risk, identify missed opportunities, and know where action is needed. So, the point or the question that I have, when you think about 340B data reporting and performance visibility, what should leaders be reviewing regularly?
So leaders should actually create a dashboard, and that's something some cover entities do. And it's as simple as find out what your expenses are, find out what your revenue is, and find out what the net profit. And that kind of dictates how you would see how healthy your 340B program is. And while you can see all that in more of an in-house pharmacy retail sense, it's harder to see that in a hospital. In a hospital 340B, mainly because reimbursement revenue data is not always available. That's what I've noticed, again, with working the cover entities that I've worked with. So for the hospital side, you'll mainly see trends in 340B cost savings. On the retail side, you'll make sure your net profits are maintained, if not in the positive. Any deviation from that requires further review. And that's what hospital leaders should kind of really look into, just these little things.
Got it. Yeah, 100% and totally agree on that. And Vincent, what matrices show that whether this program is healthy or not? Are there any specific matrices or KPIs that shows the health of the program?
So our wholesale reporting platform and kind of gives us an overview of our purchases. And I think the health of the 340B program lies on minimizing costs. And that's mainly through making sure you have a sizable 340B% purchases versus WAC. But also, you also have to make sure on the reimbursement side, the revenue side, that is healthy. They're often, more often than not, people run the 340B program without really looking at the revenue or the reimbursement. And that kind of defeats the purpose of the program because you're just giving drugs and you're not getting paid. So at least for the in-house pharmacy side, because pharmacy owns every step of the operations, we're actually able to look at how much we get paid for a drug. So I'll give you a quick example. If you have a prescription for a drug from a non-eligible 340B patient or non-eligible 340B provider, you should be buying that drug at wholesale cost, which you do. The problem is when the system identifies that transaction as 340B eligible, a modifier will be put in place, and what you'll end up getting reimbursed is at the 340B cost. So I'll give you a quick example for a drug like Jardiance, which at wholesale cost, it costs about $1,300. But at 340B cost, it costs $1. So imagine you bill the insurance at $1 plus dispense fee of $10 to Medi-Cal, and you'll get reimbursed no more than $11 for a $1,000 drug. So that's one of the things that you catch when you work on the revenue side, reimbursement side, to make sure that you optimize your 340B program and not just think about compliance.
Got it. And it seems like that if you have Vinson right dashboard and right matrices set up, it can help you to identify any missed opportunities, compliance risk, any kind of inventory issues and billing issues as well, right?
Yes.
Got it. Yeah, so it means that the reporting, it's more than a reporting tool, it's a compliance tool as well. It becomes a management tool. So let's talk about the TPS software and vendor accountability. Like many covered entities rely heavily on these TPS software, split billing system, contract pharmacy platform, and vendor management workflows. Those tools are extremely important, but software doesn't replace internal ownership. Covered entities still need to understand the logic, reports, exception, and limitation to the system they depend on. So my question is, Dad, from your experience, what should covered entity understand about what TPA or split billing software can do well, and where internal oversight is still needed?
So one of the misconceptions is that the split billing softwares, they handle everything 340B. That's not the case. And they don't deal with modifiers. They don't deal with all the in-house retail modifiers. They don't deal with the hospital claim modifiers. And with good reason, because we only have 2 states in the U.S. that have a mandatory carve-in. Anything that's carve-out, they don't need to comply with the modifier requirement. I mean, it wouldn't make sense for the 340B software to actually integrate a system that does that. So all that duplicate discount prevention lies solely in the cover entity. The 340 split software, what we can trust them to do is to help us process the data, process the transactions, whether it's be retail or be hospital, put in the accumulator, and then use that accumulator to split the purchases to actually realize the cost savings. That's pretty much all we can expect from these softwares. But if someday there comes a software that that actually does duplicate discount prevention, you know what, that would be great. But
Right.
for now, I think it's the cover entity's responsibility to
Identify
question,
this. Yeah.
identify these duplicate discounts, work with the TPA to prevent the duplicate discounts. And
Right.
that's pretty much most cover entities can do.
Yep, 100% agreed on that. So, Vincent, based on your experience, if when evaluating a TPA or 340B software platform, what are the key capabilities should cover entity pay attention to? Like key features that these are the must features that should be there.
It's funny because I maybe last week I had a meeting with a different software trying to promote the product. So then they asked the same question. So very basic, you want to make sure that that they're able to integrate all your claim files, whether it be from hospital or retail, be able to split it properly into either WAC, GPO, or 340B buckets, and making sure the purchases go through without any issues. There's some, again, not going to name names, that where there's a delay, and that's one of my pet peeves about the software, because maybe they don't ingest the file correctly. But that's the bare minimum that I would expect from the TPA for someone that's shopping around. But if I were to take the next step forward, I would probably expect now the TPA software to have a robust reporting system. Being able to generate these in-house pharmacy retail reports, being able to generate the hospital claim reports, and from my experience from the different TPAs I work with, for all the in-house retail reports, they allow the user to manipulate the claims. They allow the user to take out the claims, add claims, etc. That's great. I like that flexibility. But on the hospital side, there is no flexibility there. If you identify a hospital billing claim that is not eligible, or a duplicate claim, like I mentioned earlier, you can't just take it out. It always requires a ticket. So one thing I would have liked in a TPA is for the covered entity to have the ability to, let's say, remove claims if they want to. But again, that's a little dangerous. That's a little dangerous because what if you're wrong? It leaves more room for human error. So there's no right answer regarding this on whether humans should be involved on the hospital mixed use claims, because ultimately it's really not the splitter's fault if something bad happens. It's actually the data that actually gets sent to the splitter, whether it's through the hospital or the retail pharmacy. If the data is flawed, there's going to be issues with the accumulations. And that's what I realized, that I is mostly trying to fix all the hospital internal systems rather than fixing the TPA. There are some issues where they do quote-unquote enhancements that actually cause more problems. And that's when I identify those and kind of call them out on it and saying that, this is kind of hurting our program. Can you revise your quote-unquote enhancement?
Got it, right. So, Vincent, what questions should cover entities ask their TPA or software vendor regularly?
So I used to be on these like biweekly calls with TPAs, and lately a lot less. But but mainly, it's more to like follow up on their latest enhancements, see, what they have in store for you. So like we get these emails from them saying that, oh, you know what, there's a new software there's a new addition to the software that allows us to allow you to manually adjust your claims. It's good to question them on, what the enhancement entails, and see how it impacts your program. This is me speaking from a program that's been refined, that everything is, I guess, smooth. And what you're actually looking out for is any changes in the TPA that would impact your program in any way. So these are the questions that I would probably ask on how does this impact my covered entity, all the updates that you plan to do.
Got it. And Vincent, you may have heard about a lot about AI, automation, and everything. Do you think AI can play a role in preventing the duplicate claims issue?
I would have liked that, honestly. Like if AI can prevent that, that would be great. But again, you run into another issue where you rely on automation so much, where some issues can still exist in a different form, and it still requires a person to kind of catch that.
So there should be human in the loop who can.
There should always be a human in the loop. Yeah.
And Vincent, I have also heard about people a bit worried about data security, privacy as well, because it contains like RX number and some other like patient information. So so they wanted to stay compliance as well. They are like worried that they're not violating any, because AI, a lot of people have issues with all the security guardrails and all these things. So what are your views on that part?
I think not speaking for AI, but there's a new 340B rebate program that you probably heard of, and it's managed by Second Sight Solutions, and because we currently have some covered entities participate in 340B ESP reporting, and I have to go into the operations to kind of see how it works, and they do de-identify the data, whether it be Beacon or ESP. They do de-identify the RX numbers when it gets submitted. So in terms of HIPAA compliance, any data breach, and I'm not saying we should trust the system, in declassifying data because they say they do. Again, it's always good to question it, but I wouldn't know where to start in trying to evaluate how effective it is in maintaining privacy.
And have you seen like any of these TPA? You mentioned you were on the call with these TPA software vendors about weeks ago. Have you seen, have they started adding any AI features, any automation in their softwares lately?
So the presentation that I was presented was just about reporting analytics. It's something that I can just get from the wholesaler, and it didn't really provide too much value to me. And in terms of automation, I think it was great that they were able to, kind of find cheaper alternatives or what NDC drugs are a cheaper option. But again, this is something that you just get from the wholesaler, and wholesale reports can't offer the same level of data as well. So this particular TPA was a little unique because it is integrated with this wholesaler together. So that's why they were able to provide that these type of reports. But in terms of automation, again, I'm only limited in what I kind of expect the 340B TPA to do, to ingest the data, split the data, and go into purchasing. I have yet to see one where they take into account carve-in covered entities and prevent duplicate discounts. If there's automation that allows for that, that would be great.
Got it. Yeah, 100% agreed on that part. So Vincent, what are your views about this rebate program that HRSA was going to launch at the start of this year, and then it went on pause due to the court intervention. Do you think is it going to add more transparency to the program, or is it going to add extra layer of reporting and check and balances on the cover entity end?
I kind of, so part of being a consultant is not just working for the cover entity, but also kind of understanding the manufacturer standpoint.
Yeah.
And from their standpoint, because of the new, I believe the MFP refunds that are initiated under the IRA, that kind of causes lack of transparency in, on how to assign how much refunds are through MFP. So I'm not saying it would help, but they do. Manufacturers do need some level of 340B data to identify which claims should be 340B and which claims are not 340B or MFP. Recently, CMS posted I believe, a 340 repository, and from what I think is basically uploading 340B data, and what it informs CMS is, this drug A, you have dispensed X amount of quantity. Right. So under 340B. So I think that would probably be a better approach, because it would help facilitate the MFP. In terms of the 340 rebate, I think it kind of aims to kind of reconcile that piece, but because the 340 rebate applies to all drugs, I don't think a lot of cover entities are on board with it. It's more work. But in the end, because I dealt with ESP, it is similar in that sense, where you pretty much map all your columns, headers, and then you upload the file.
Yep.
And then another issue is HIPAA privacy. There's no validation that they will maintain patient confidential data. Yeah. So I would say, I'm a little 50-50 between the two, whether I think it would fit or not. And just to add another layer to the mess, you have hospital claims data. Like, how does that work? With the hospital dispensations, and it's just not feasible in that sense.
Yeah. And I believe another point is that it's going to create a lot of clerical and lot of administrative work on small cover entities, which are having less staff members, and also cash flow issues because they have to pay in the advance if this become functional. Yeah. All right. So at the start of this conversation, we were talking about, Vinson, your experience with HRSA audit. So for our audience, can you share that experience? How was that experience, and how they can be better prepared if there comes any HRSA audit? Any finding, any tips for the people?
Drink a lot of coffee. You need to stay alert, because once they announce that you have a HRSA audit, you pretty much have your next month or two booked just for gathering data, because there's a lot of back and forth between the cover entity and the HRSA analyst. And because I mainly work with the operational piece, there's some layers of it, more the administrative side, where I can't say I'm too familiar with, but again, it's just a bulk of it is just data gathering, making sure that the data you get is valid. And HRSA will audit only on the data that you submit. They will not look anywhere beyond the data that you submit to HRSA for sampling. It's just something that cover entities should be aware of. And if there's any issues with the claims when you gather the data, make sure you address those as soon as you can. And on the day of the HRSA audit, which lasted about 2 days, is mainly just going over the samples, and it's good to have two people involved, like with me and an analyst that I work with,
Right.
and it's just a lot of question answering. And one key thing to note for the HRSA audit is you have to understand the process, understand your pharmacy process, understand your billing process, understand the IT process. So whenever any questions arise, you are prepared. And it's good that the HRSA gives you the samples about 3 days in advance, because it gives you
Right.
time. Yeah, it gives you time to think about your samples and how the best way to approach the auditor when you present them.
Yep. All right. So, Vincent, before we close, I had loved to do a quick rapid fire round. So, short answer are perfect here. The goal is to give listeners practical takeaways they can remember. So, let me know when
Okay.
you are ready.
Yeah, sure. Let's go.
Right. Okay. So, what is one duplicate discount prevention issue covered entities should never ignore?
Well, they should never ignore the data. They should always have basically at minimum 2 data sets available: pharmacy data and 340B data. And that is pretty much the bare minimum that you need to identify claims to prevent duplicate discounts.
Got it. What is one mixed use hospital operation issue that can create risk quickly?
In speaking for the hospital, check your hospital billing files that are sent to the 340B TPA, because that pretty much dictates whether you're in compliance or you are at a risk of a loss of 340B savings. So just check the primary file that you submit to your 340B TPA. So in most sense, it's the charge files.
And what is one report every 340B leader should review regularly?
The dashboard. If you can generate a dashboard that outlines your purchases and revenue, that's pretty much all you need.
And what is one question every covered entity should ask its TPA or software vendor?
There are so many questions. So, but one primary question I would ask is it working as it should? Is it accumulating as it should? Is it processing claims as it should?
Got it. Last but not least, what is the one habit that helps teams stay audit ready throughout the year?
Perform monthly internal audits, perform quarterly external audits with any vendor. If you struggle, get a consultant, get someone who can kind of navigate through the ins and outs of the 340 program, and not just pharmacy, but also IT and billing and finance.
Well, that's awesome. Thank you, Vincent. It was really great. So, Vincent, we have covered duplicate discount prevention, mixed use operations, data reporting, TPS software visibility, and vendor accountability. If you could leave cover entities with one practical takeaway about building strong 340B oversight, what would it be?
The one thing that the HRSA auditor left with us an impression is that it's not just the 340B team, it's a team effort. So find a way to connect all the operations of the hospital together. Find a way to connect pharmacy, billing, IT, finance together. Once you're able to find someone or something to keep these together, then it gives you a better understanding on how it works, how to troubleshoot issues, and even how to optimize the program.
Got it. Well, Vincent, thank you again for joining us and sharing your experience. For anyone listening who would like to connect with you or follow your work, what is the best way for people to reach out to you?
I don't know, my email is posted. They could shoot me an email, or they can look me up on LinkedIn.
Awesome. Thank you again. And to everyone listening, thank you for joining us. 340 Peoples, a North Arc Health podcast powered by Purolix. I'm Muhammad Atif. We shall see you in the next episode.